Dr. Daniel Hayes from the University of Michigan Comprehensive Cancer Center in Ann Arbor will now discuss this last abstract.
Thank you, Dr. Sykoff and Dr. Andre. It's a privilege. I assume that since Professor Andre got 25 minutes, I get 30 minutes, right? It's a pleasure to really be here and have an opportunity to discuss the STIC trial, which obviously I have followed quite closely over many years. And I guess I'm doing the next slide, right? What do I punch?
There you go.
Great. Unlike most of my predecessors over this session who have said, these are my conflicts, I'm going to go to the next slide, I'm going to spend some time on my conflicts. I have some very, very real conflicts, and I want to be quite transparent in declaring them. First of all, I've had a long history of working with circulating tumor cells using the specific assay, cell search, that was used by Professor Bedard and his colleagues from Curie. I've gone through 4 different companies with cell search: Immunicon, Veridex, Janssen Diagnostics, and more recently, Menarini Cell-Link Biosystems. I've received laboratory and clinical research from each of them, including MSB most recently. My institution owns a patent regarding circulating tumor cells in which I am the named investigator. We have licensed this to MSB, and we received annual royalties up until 1 year ago. I also have some novel CTC capture device patents pending but are not yet approved. So please take everything I say with a grain of salt. I'm going to try to be as objective as I possibly can. I first thought about declining the offer to give this talk, but then I thought, who knows more about CTCs than me and about 5 others of you in the field? And so I elected to take it. Now, let's first of all talk about what we're trying to do. And this is a little bit like when Knute Rockne, the famous football coach at Notre Dame, and they were getting beat very badly in the first half, and they went into the locker room and instead of telling them X's and O's and new plays, he pulled out a football and he said, "Gentlemen, this is a football." And that's kind of where I want to start here as clinicians. Every one of us sees a patient with metastatic disease, and we have 2 goals of therapy. In fact, this is true for medicine in general. One of those, of course, is to make people live longer. Overall survival is the primary endpoint. But if we can't do that, then we are trying to make people live better, quality of life and palliation. We're not necessarily trying to make people live longer without progression. That's often an endpoint we use, but that's a surrogate for one of these 2. And in fact, everything else, response rate is also a surrogate. I know this is clinical oncology 101, but sometimes we forget this in these presentations. So in fact, does giving chemotherapy instead of endocrine therapy as first-line treatment for patients with estrogen receptor-positive metastatic breast cancer make them live better or live longer? And this is an overview from the Cochrane database published by Wilkin and his colleagues over 2 decades ago, in which they looked at all the old randomized trials of chemotherapy versus endocrine therapy as first-line treatment. And what you can see here in the forest plot on the right is response rates are almost identical. Mortality was almost identical at 12 months and at 24 months. And they concluded that this review found that while initial treatment with chemotherapy rather than endocrine therapy may be associated with a higher response rate, the 2 initial treatments had a similar effect on overall survival, and they could find no single group of patients who might benefit from or be harmed by one treatment over the other, although there was little information to address this question. Now, these and other data were used by the ASCO Oncology Guideline for Endocrine Treatment for Hormone Receptor-Positive Breast Cancer, led by Dr. Rugo and many other people in this room, I suspect, are sitting here. I don't know if either of you are on here or not. I forgot to look. But they concluded, when what comes as no surprise, is that endocrine therapy should be recommended as the initial treatment for patients with hormone receptor-positive breast cancer, except for patients with immediately life-threatening disease or those experiencing rapid visceral recurrence during adjuvant endocrine therapy. And I suspect that every one of you who is a medical oncologist in this room treats your patients exactly according to these guidelines. I certainly have for the last almost 40 years now. So can we do better? And in fact, I found this entire morning session to be really fascinating because it relates to a lot of what I'm talking about, but in greater detail. One of the issues is, can we use circulating tumor cells measured by cell search prior to starting a new therapy? And there are several studies, these are essentially outdated, but they set the table, showing that if you have elevated circulating tumor cells, defined as greater than or equal to 5 circulating tumor cells per 7.5 mils of whole blood, prior to being treated with any kind of therapy, and if you have metastatic breast cancer, colorectal cancer, prostate cancer, lung cancer, pancreas cancer. I ran out of room on this slide, so I just kept it like this one. Fundamentally, having circulating tumor cells in your blood, if you have metastatic disease, is bad. Now, let's go to how do we make that better. And I give great credit to Professor Bedard and his colleagues from the Institute Curie for running a prospective trial to test whether or not we could change the overall guidelines. Their hypothesis, as you've already heard, is that baseline CTCs could be used to guide choice of first-line endocrine therapy versus chemotherapy for hormone receptor positive, HER2 negative metastatic breast cancer. This gets back, some of you have heard me say, at the end of my lab meetings or at the end of my clinical research meetings, often presented by some really excited young fellow, I will look at them and say, so what? Which is pretty devastating for an old guy to do to young people, but except what I really mean is, think about what you're going to do with these data as a doctor tomorrow in clinic. And the so what here is, okay, CTCs are prognostic, so what? The so what is, can you change therapy and make people either live longer or live better? Their hypothesis was that if CTCs are elevated, prognosis is poor, so you should use chemotherapy first. Just like we try to use our clinical judgment that if we think a patient's going to progress rapidly or be in visceral crisis, we should go to chemotherapy first, as the guidelines suggested. And if they're not elevated, then prognosis is so favorable that the standard of care would be to use endocrine therapy first. In other words, do CTCs at baseline have clinical utility for treating this group of patients? That phrase in blue, clinical utility, harkens back to a committee put together by the CDC called EGAP, in which they proposed 3 components of any tumor biomarker test. One of those is analytic validity. Is this a good test? Is it reproducible? We had a whole discussion yesterday about HER2 low on whether that's a good test using IHC. The second is clinical validity. Does the test split the patients into 2 groups that do differently in some way? That doesn't mean you should use it. The so what is clinical utility, and that is, does use of the test make people do better than if you don't use the test? I had the opportunity to write a single-authored commentary about 2 years ago in JCO, which was pretty arrogant on my part, except this was a culmination of about 30 years of my thinking about what is clinical utility, even before that word had been articulated, and discussions with many people, including several in this room. And I finally decided these were my opinions, and I couldn't ask all these people I'd spoken with over 30 years to co-author a paper with me, so I acknowledge all the people who helped me do this. I don't tell you what clinical utility is. What I tell you is what are the factors you have to think about. You can't just say, this is clinical utility. They are, of course, analytic validity. It's got to be a good test. I just discussed that. But also, what's the context? Which malignancy are you talking about? What setting? Which use, prognosis or prediction? What's the endpoint you're going to use to decide that it really has clinical utility? Are you going to use something like overall survival or quality of life? That's what we really care about. Or the other surrogate endpoints or toxicity. The third is, how much difference does there need to be for people who are tumor biomarker test positive versus those who are negative relative to whatever you're going to do based on the marker? And some of us will say a small difference is all you need. It depends on the toxicities and the cost. Others will say it's got to be enormous to justify whatever you're going to do. Finally, who makes that decision? And I'm going to talk about that later. And finally, what are the levels of evidence to actually demonstrate that your estimate of magnitude is really worthwhile for that endpoint in that context? Now, how do we decide that level of evidence? And there are 3 papers I think anyone who's in this field should really study. One of them is I'm an author on, so of course I think you should read that and cite it, but that's not really why we're here. I'm not going to talk about this, and that's whether you can use archive specimens. We heard a lot about that yesterday to get to clinical utility. But the late Dan Sargent who was at the Mayo Clinic. Many of you know him. And Boris Friedland and his colleagues at the NCI published 2 papers very close to each other in which they wrote out how to do prospective clinical trials in which the marker is the primary objective. If you're in this field and you haven't read these papers, you should. If you have these papers, you should keep them on your desk open all the time. They're wonderful papers, and I memorized them basically. So our colleagues from the Curie read these papers, and they took one of the approaches led by both Dr. Sargent and Professor Friedland to design the STIC trial. And again, congratulations. I took a lot of courage. We've talked about this offline, by the way. And you've already seen this trial. One of the things I want to say about this trial, though, is they selected a relatively inefficient approach, and that is they randomly assigned patients to use the CTCs or not use the CTCs. And the reason it's inefficient, almost half the patients, I believe you said, Professor Bedard, ended up, the CTCs really didn't help any. You treated them the way you're going to treat them anyway. So half the patients in this relatively small trial ended up really not providing much information. It was only the patients in which there was a CTC difference that was of importance. And this is probably the key trial, is that overall, upfront, treating patients designed by CTC direction or just treating them the way you were going to didn't make a difference in either progression-free survival or overall survival. But, and as Professor Bedard already pointed out, the big but, the so what here, is that in patients in which the clinician felt the patient was going to do quite well and probably should get endocrine therapy only, if you used CTCs to direct therapy, there actually was an overall survival benefit for those who had elevated CTCs and got chemotherapy first versus those who didn't get endocrine therapy, a paradigm-changing observation if we accept it. And I give them credit for this. This is a terrific observation. But, and there's some buts. Several caveats. And in fact, I wish I had heard the entire morning session before I made these slides, because many of these things were addressed this morning. But I want to point out, first of all, there was an overall survival benefit in those who were clinically low but had elevated CTCs. There was not an overall survival benefit in those who were clinically low, CTC low, clinically high, CTC low, or clinically high, CTC high. So the suggestion there is you just should treat those patients with standard of care anyway. But perhaps what you could say is in patients who had clinically high but CTC low, it looks like they did about the same. Maybe our ability to determine visceral crisis or rapid progression isn't very good, and CTCs might help here, although it's not entirely clear that's true. And as we've already discussed, Dr. Bedard also pointed this out, there was no ancillary treatment with endocrine therapy. The CDK4/6 inhibitors, everolimus, alpelisib, the oral SERDs we heard today about, the AKT inhibitors. Again, there are a number of more modern treatments that just didn't exist when they started this trial. It's not their fault. You didn't anticipate the progress that we've made, and I didn't either. So it's hard to say. And there was no downstream treatment with recently proven therapies, such as trastuzumab deruxtecan that we've also heard quite a bit about, the first standing ovation I've seen in about 10 years at ASCO last year. More importantly, let's go back to there was no ancillary treatment with CDK4/6 inhibitors, and as my friend and chair here already pointed out and stole my thing, we had a presentation 2 days ago by Dr. Liu and his colleagues that in fact this very group of patients in whom they felt had rapidly progressive and possibly visceral crisis were randomly assigned to ribociclib and endocrine therapy versus combination chemotherapy. And if anything, the patients who got endocrine therapy plus ribo had a better progression-free survival than the patients who got chemotherapy. They, by the way, also had better quality of life. Okay, so other caveats. No serial CTC data. One of the questionnaires asked about that. I agree. I think that's a huge deficit. Dr. Bedard and I have talked about this. Not his fault. They didn't have funding to do it. We have published, and by the way, all these references are from our group. It's not we're the only ones working on this. It's just I don't have room to go through everything, so I put ours as examples. But Jeff Smiraj in SWOG published a paper in which we looked at whether a first-line chemotherapy could be directed by CTCs. The answer is we found that they had a horrible prognosis if they didn't clear their CTCs with one cycle of chemotherapy, but changing chemotherapies didn't help either. One of the questionnaires asked about, well, why can't we have this anymore? That study is probably the reason, is that the third-party payers decided there was no real advantage in knowing it. How about second or third line endocrine therapy? Costanza Paletti, who was in my lab for about a decade, published a very nice paper in which we actually tried to find the kinds of things that Professor Andre talked about earlier, and that is, can we identify the patients who progress so rapidly that even if they're ER positive, they must have endocrine refractory disease? It is true that elevated CTCs at baseline did that. It's even more true that not dropping your CTCs after 1 month of treatment was even worse. But it wasn't necessarily true that meant we should change their therapies. There was no CTC characterization, and the field has really moved forward in terms of its phenotyping. We can do ER, HER2. In fact, we can do 6 or 7 different phenotypes right now, and we've had a number of trials and studies going on to look at that, including we are also a lab on one of the oral SERDs we heard about, and we're going to be presenting those data, I hope, next year. CTC genotype along with ctDNA genotype. And again, we and others have reported that we can do single-cell genotyping quite easily. Professor Canny, or Dr. Canny, is in my lab, a postdoc, and was supposed to have an abstract today, but his airplane got grounded yesterday and he couldn't get here. But anyway, lots of people are doing this, and I think the single-cell symposium yesterday, single-cell sequencing, was really fascinating on our ability to start pulling out the biology of these cells and the genetics of these cells, and then starting to ask, can we identify people who aren't going to benefit from endocrine therapy and ought to get something better? And I think we're on the verge of being able to do that. So if we go back to the STIC trial and my little factors, the analytic validity is excellent. The context was well chosen and an important one. The endpoint is the one most important to us, improvement of overall survival. The magnitude is moderate. You could say it's large. Again, this is a matter of perception. And the level of evidence is probably 2 or 3, since this was, although prospective, a subgroup and relatively small. It could be a false positive. I'm not sure about that. And the question is this enough to change practice? My conclusions are probably not. This was a prospective randomized clinical trial. Overall survival was improved by selecting chemotherapy first, and I give them credit for designing this trial and having the courage to go through with it. And patients with clinical high, low CTC avoided chemotherapy. That's another advantage, but it's not clear to me that this whole thing is sufficient for clinical utility in context of what we know today. And then that means who decides? Is it the patient? Is it the caregiver? Is it expert guidelines panels? Or is it the people who actually pay the bills? And one reason we don't have CTCs available is because the people who pay the bills decided it did not have clinical utility after the Smiraj study, and they wouldn't pay for it anymore. And that's the answer to the question that was asked to Professor Bedard, but he couldn't respond because he doesn't practice in the United States. So having said that, I think we should all think carefully about this. I don't think the world of CTCs is dead. I think they're part of liquid biopsies. We should continue them so we can look at phenotypes, individual cell CTCs, and complement ctDNA. Having said that, thank you very much. Thank you for the invitation. And please remember my conflicts of interest in this talk. But again, I hope I've been objective.
Thank you, Dr. Hayes, for your discussion. Dr. Anders and I want to thank all of the speakers for their outstanding contributions to this session, and to the attendees, both in person and online, for your attention and for the questions submitted for our presenters. This concludes General Session 3. We invite you to join one of the next scheduled sessions.